Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. I'm Dr. Gregory Leach and I'm here with my co-host Jim York. We're interviewing Dr. Raymond Phillips tonight. He's a practicing gastroenterologist in Naples, and we've had you on the show before, and we're welcoming you back.
Well, thanks for having me back, Jim.
Great. Thanks for coming back. Dr. Phillips, just tell our viewers again a little bit about your background and where you're located here in Naples.
Absolutely. I'm a board-certified gastroenterologist, and what that means is an individual who's gone to college. I went to Princeton University, graduated from there, and went on to medical school, Washington University in St. Louis. And then after 4 years, graduated from there, and then I did my internal medicine training at Jefferson Hospital in Philadelphia. And I was selected for a fourth year as a chief resident, and after that fourth year, I went on active duty because I'd gone through college on an ROTC scholarship, an Army ROTC scholarship, and I went on active duty and was assigned to Fort Leonard Wood, Missouri as an internist for 2 years. And then I was selected for gastroenterology training and did my training at Walter Reed Army Medical Center for 2 years. And then I was on staff at Walter Reed for 2 additional years. And in 1991, I came out of the Army and entered private practice and came down here to Naples. And I've been here in Naples since 1991. Now, I practice with Dr. Susan Lebersky, Dr. Neil Randall, Dr. Michael Marks, and our newest associate, Dr. Gustavo Rivera. And we have offices not only in Naples in Colonial Square, which is on Goodlet Road, but also we have offices in Bonito Beach Road, as well as in Marco Island. But all this is just a preface to say that a gastroenterologist has a very, very long and extensive training. I'm board certified in gastroenterology. I underwent a certification examination. And our specialty deals with gastrointestinal ailments. That is to say, of the gastrointestinal system, the liver, the pancreas as well. But also we're specifically trained in nutrition and nutritional science. Only specialty, by the way, that is trained in that. So we're well placed to handle a number of different issues that come up.
And we've talked about a few of those issues with you, but tonight we're going to talk about inflammatory bowel disease.
Right. Well, inflammatory bowel disease is, it refers to a number of different entities, and it's worthwhile to have an understanding of what we're talking about first, because over the last 75 years, there's been an evolution of our understanding of inflammatory bowel disease and a clarification of what it represents, and also a discovery of other conditions that are very, very similar as far as symptoms, and sometimes can be rolled into consideration of that, but they're really a difference. And inflammatory bowel disease, the two principal diseases we're talking about are ulcerative colitis and Crohn's disease. And many people will have other symptoms that they'll refer to as colitis, but it may well be, and more likely is, something called irritable bowel syndrome or some other condition. Those individuals who have inflammatory bowel disease, Crohn's disease, or ulcerative colitis, they have very, very specific symptoms in general. They'll have diarrhea, bleeding, abdominal pain, weight loss, but there are also symptoms that can be seen in other parts of the body: visual problems, oral ulcers, skin rashes, arthritis. So it's not just a condition of the gastrointestinal system, it involves the entire body. And the fundamental feature of it is that there's inflammation of the gastrointestinal system. Now, that was our understanding for years and years, but in the last 20 years, we've had much, much better clarity as far as actually what provokes the inflammation. And that's the part that's been very exciting, because as we've understand what actually causes the inflammation, we've been able to develop more effective treatment that's very targeted at what stimulates or provokes the inflammation. Now, now you might say, well, what causes the inflammation? Well, it relates to the immune system. And a lot of people don't appreciate this, but 80-90% of your body's immune system is directed toward the gastrointestinal system. And that's where, if you consider, where you come into contact with most of the proteins and germs throughout your life and throughout each day is through your gastrointestinal system. So your body directs most of the efforts around the gastrointestinal system in an effort to prevent infections from developing, but modulating and moderating the bacteria that exist within our gastrointestinal system. And so what will happen, we're increasingly learning, is that some individuals will have an alteration in their immune system, and in particular their immune response to a particular bacteria within the gastrointestinal system, and that immune response leads to inflammation in the gastrointestinal system, an abnormal immune response. Now, this can get real technical in terms of how this occurs, but I just want the viewer just to have a general understanding that there's an interaction between the bacteria in the gastrointestinal system, your immune system.
Right.
It exists in harmony. It's only when there's an aberrant or an abnormal immune response do you start getting inflammation of the gastrointestinal system. And that inflammation then, in a sense, a simplistic sense, your immune system believes there's an infection in your gastrointestinal system and mounts an immune response to attack that area of the colon.
And what percentage of the population have this?
Well, it's anywhere from 1 to 2%.
Okay.
1 to 2% in that range. And typically what occurs is there's anywhere from 10 to 20 new individuals per 100,000 that are diagnosed each year. But once you become diagnosed, the condition is often lifelong. It may go into remission, and may not be as severe. But so the general prevalence in the population, well, 1 to 2% of the population. And so it represents a substantial number of individuals within the United States that have this condition. Now, what distinguishes Crohn's disease versus ulcerative colitis? In general, ulcerative colitis is inflammation of the colon. But Crohn's disease, or when I say colon, I mean large intestine, but Crohn's disease can involve inflammation not only of the large intestine or colon, but can involve inflammation of any portion of the gastrointestinal system, in particular the small intestine, but it can involve any portion. Interestingly, the underlying cause for each is very similar in terms of activity of the immune system, an abnormal response to the immune system. And interestingly, the treatment for the two is very similar as well. And so oftentimes some of the same medications that are used for ulcerative colitis are used for Crohn's disease. Now, the reason I was particularly interested in addressing this in the context of this show is that there's been a great number of new developments in inflammatory bowel disease in the last 2 or 3 years, based on this understanding that I've just described to you, based on this model now of an interaction of the gastrointestinal bacteria with the immune system, moderated by the individual's underlying genetics, and possibly influenced and likely influenced by dietary changes. Now that we have a better understanding of the specific steps here, we've been able to develop very, very particular medications that have been extraordinarily effective. And so we've gotten real excited about that. And now we're being much more effective in terms of allowing people to be successful as far as treating this and putting them in remission. Now, to go back and give you a little historical perspective of these two conditions. Generally, it was Crohn's disease, which is named for Dr. Crohn, who discovered this in the late 1920s, and it involved principally young people, and that's why its impact is so marked, because you're involving young people. When I say young people, children or young adults in their teens or 20s, and oftentimes affecting them throughout their lifetime. Ulcerative colitis has a similar distribution, young age as well as an older age. The most prominent person who ever had ulcerative colitis was President Eisenhower in the 1950s during his presidency. And he nearly died from this, correction, he had Crohn's disease, not ulcerative colitis, but he nearly died from Crohn's disease. And that's sort of another story I'll have to tell you at another time. Well, I'll tell you right now.
Good.
It's kind of interesting. He was cared for at Walter Reed at the time, and it was in the late 1950s. And he was told he was on extended sabbatical, and since he was playing a lot of golf, a lot of people didn't notice the presidents back then. And but he lost 50 pounds related to the Crohn's disease, and it involved a circumstance where he had such severe inflammation that led to an obstruction of his gastrointestinal system. And it was decided that the president needed to be operated on, and they operated on the president. And at the time, there had been some new changes in surgical technique. So the chief of general surgery, who was operating on the president at the time, called in the chief of gastroenterology for a consultation during the operation on the president. And so while the president's open belly was there, they were having a discussion about what kind of operation they were going to do based on what they had found. And what they had found was a complete blockage of the gastrointestinal system. And the surgeon wanted to do a bypass around the blockage, and the blockage developed as a result of chronic inflammation leading to scar tissue that gradually caused a narrowing. The gastroenterologist recommended the latest new techniques, suggesting, well, you just don't bypass it, you remove it, and then reestablish continuity. Well, they had an argument, and surgeons being surgeons, they prevailed. The surgeon prevailed. He said, I'm going to do the operation I've been trained to do, and he did the operation. The president recovered, and he recovered his health and went on to conclude the presidency. The surgeon went on to become Surgeon General of the United States, and the gastroenterologist who lost the argument was assigned to a post out in Alaska. And so necessarily being right doesn't always lead to the best outcome for all participants. But in this circumstance, it worked out well for the president. But there have been great advances now as far as therapy for Crohn's disease and ulcerative colitis, not only in the surgical field, but the medical field. And for years, the only treatment for both was steroids, which had so many side effects and fraught with so many difficulties that it was recognized, even though it was initially hailed in the 1950s as a cure-all, it was realized quickly there are so many side effects that something, and it was not a cure-all, that more effort needed to be done in terms of treating. And another drug was developed initially as an anti-inflammatory called azolfidine, but it was discovered and it reduces inflammation in mild cases of colitis or Crohn's disease, but not very effective, and except for mild ulcerative colitis and very, very mild Crohn's disease. And then over the years, variations of azolfidine have been developed: aprezo, dipentum, lialda, azicol, delzacol, but all variations of the same thing. The same drug as azolfidine discovered 60 years ago. And then about 30 years ago, it was discovered that, hey, if you modulate the immune system, you can actually improve both of these conditions. And drugs that had been used for chemotherapy, one of which was called 6-mercaptopurine or azathioprine, turned out to be very effective for that purpose and helped about 60 to 70% of people. But in year 2000, for the first time, with our understanding of the immune system and how it plays a role, a drug called Remicade, a new category of drug, was released for the first time. And that was a category called biologics. And that's been terribly exciting over these last 14 years, because biologics, and the reason they're called biologics is that they're actually represent antibodies that are constructed. And they're constructed with the specific purpose of latching on to inflammatory messages and preventing those messages from telling white blood cells that there's inflammation that needs to be, telling those white blood cells to be activated. And so with this specific antibody constructed with great effort using sophisticated recombinant DNA technology, we're able to construct an antibody that attacks by latching on to these inflammatory messengers and preventing this inflammatory message from being released from the immune system and directing white blood cells to lead to inflammation. And so it's been very, very effective, and new versions of this drug now have been released. Subsequent ones have been Humira and Cimzia, are variations of the same thing.
We want to take just a short pause, break, and we'll come back and talk more about these engineered biologics in just a minute.
Okay, great. So the
When picking a realtor, don't just pick anyone. Pick someone with experience. Pick someone with a proven track record. Pick a realtor like Jim York from Downing Fry Realty, the #1 brokerage with the most real estate transactions in the area.
My husband and I had very specific ideas about what we wanted in our new home. Jim York was able to help us find the home that was ideal for us.
With over 20 years of real estate experience in Southwest Florida, Jim York has negotiated over $200 million in sales contracts. Selecting the right realtor is a critical decision that can earn you thousands when selling or save you thousands when buying.
Jim also helped us with a mortgage lender and a good real estate attorney. He went that extra mile, and his experience says it all.
Call Jim York for a no-obligation meeting at 239-273-6727 or visit his website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. We're here this evening with Raymond Phillips, practicing gastroenterologist in Naples, and we're talking about ulcerative colitis and Crohn's disease. They're both inflammatory bowel autoimmune diseases, and we're now going on to talk about how to modulate the immune system of the patient with these biologics.
And again, biologics, and break, you were asking me about these drugs a little bit further, and to recap, there's Remicade that's been available for 14 years, Humira that's been available for 10 years, Cimzia that's been available for these last 6 years, and they are constructed antibodies that attack the messages that are released from the immune system, activating white blood cells to cause inflammation, and those messages are blocked. In very, very closely monitored studies, we have a clear idea about the side effects of these drugs. And since it interferes with a component of the immune system, it can make an individual a little more susceptible to certain infections, like fungal infections or tuberculosis. Sometimes it can make you a little more susceptible to reactivation of hepatitis B, which is rare in the United States. There's a slight increase in the risk of a certain kind of cancer called lymphoma. Now, each of these conditions has a background rate of lymphoma, about 2 in 10,000. When you use this medication or any one of these medications, that background rate increases to 4 in 10,000. So it does increase the risk. But on balance, the response in individuals in whom they're treated, because this medication is reserved for moderate to severe disease. And individuals with moderate to severe disease, they are really sick. They are really affected by these conditions. So severely that these individuals are having bleeding, weight loss, can't leave home, can't work because of the frequency and urgency of the diarrhea that they're experiencing. So for these individuals, it's been quite traumatic as far as their response to therapy. But not every individual responds. And what we found over those last 10, 12 years, about 2/3, 70% of individuals respond. About 1/3 doesn't fully respond and or does not respond at all. And so that group of individuals has been an increasing problem for us, trying to find a medication that works for them. In Europe, there's other medications that are used, other chemotherapeutic medications, but the emphasis most recently has been looking to other biologic drugs, other constructed molecules, because now we're learning that the immune system is extremely complex, and there's several different mechanisms by which your immune system is able to cause inflammation, and there's actually a very good understanding now of why so much of the immune system is directed toward the GI system through the development of some of these products. What we've learned, I'll just digress for a moment, this is really, really interesting, is that immune cells, they circulate through your entire body. But an immune cell, which will help recognize an infection and attack an infection, it circulates throughout your bloodstream. But periodically, it goes back to the gastrointestinal system and resides there for a time. And then periodically, that same immune cell will go back into the circulation, circulate around, and then come back to the gastrointestinal system. The question we always had is, how in the world does the immune cell know where the gastrointestinal system is? How does it know where to go in order to, and what we've learned is that as immune cells percolate through the blood system, as it comes to the blood vessels that are involved with the gastrointestinal system, the little capillaries that line the gastrointestinal system have very, very particular protein markers, sort of like exit ramp markers, if you will, on an interstate system. And the immune cells have a comparable protein that links up with that marker. So it's able, as it goes by, it latches onto that protein and takes the off-ramp onto the, and stays in the immune system. So that's how it's concentrated in the gastrointestinal system. And knowing that recently, we've developed another biologic that interferes with immune cells so they don't, inflammatory immune cells don't stop at the gastrointestinal system and don't congregate there as much, and correspondingly lead to a reduction in terms of inflammation. And this is a drug that was released most recently called vedolizumab for ulcerative colitis as well as Crohn's disease. And that's an exciting new addition because it works differently and now allows us to treat those individuals who have not responded well to these first class of drugs are called anti-tumor necrosis factor, anti-TNFs. So the point being is we're developing other, with our understanding of the immune system, we're developing other biologic antibodies that can be used to help those individuals who are not fully responding. So it's an extremely exciting time for gastroenterologists, but it's difficult for us to transmit this excitement to our patients who are concerned about and worried about potential side effects of these drugs, and the fact that although these drugs are very effective for reducing inflammation and getting an individual back to normal, they don't necessarily cure you. So you need to continue to use these on an ongoing basis to keep that inflammation at bay. And so it's been a little bit of a frustration that way, but this, nonetheless, in these 15 years, what we've seen is a dramatic decrease in the need for surgical intervention for individuals with Crohn's disease and even individuals with ulcerative colitis. Now, the role I just said, just recounting that experience with President Eisenhower, the role for surgery in the context of Crohn's disease was oftentimes treating a blockage. And an individual, if they develop Crohn's disease at an early enough age, they might have 4, 5, 6 different surgery in the course of 50 or 60 years. What we're seeing in the last 15 years, individuals with Crohn's disease who are on these biologic medications, the need for surgery has plummeted. That is to say, these individuals are not having inflammation, not leading to scar tissue, not causing the blockage. Similarly, in ulcerative colitis, we're finding we're able to reduce the inflammation so effectively that the need for removing the entire colon, which is the surgical response for ulcerative colitis, is not as necessary as it was, or not as used as frequently as it was even just 10, 15 years ago. So we're making great inroads as reflected by decreased need for these major surgical interventions for both of these conditions. But one of as a result of developing this understanding of the immune system, we're realizing that where before our goal had been to comfort our patients and reduce symptoms, now we're coming to the understanding that if we're really going to make a difference, we got to eliminate inflammation in the gastrointestinal system. After all, it's called inflammatory bowel disease. And what we've come to the conclusion now, and particularly in the last couple of years, is if we can eliminate inflammation, we will prevent some of these adverse events in terms of long-standing disease, the scar tissue that leads to blockage, or the inflammation that over time might make an individual more susceptible to colon cancer or small intestinal cancer. And these are things that are seen in both Crohn's as well as ulcerative colitis. So now there's a realization that now we have some tools, that is to say these biologic medications, that now allow us to be able to actually reduce inflammation so that individuals' gastrointestinal system can become normal once more.
And you talked about remission very early in the discussion, but then later on you implied that somebody who's taking Remicade, for example, will be taking that for the lifetime. Well, are they ever in remission to where they remove treatment?
Well, there have been instances where people who have been on Remicade or Humira or Cimzia for a number of years have been able to successfully reduce or even stop those medications. But when that happens, when a person stops those medications, there's a real risk, almost a 50 or 55% risk over a 2-year period of a reactivation of that condition. Mm-hmm. So the underlying circumstance that led to the ulcerative colitis or Crohn's disease still exists, and what we believe happens is it just sort of reactivates once more, and that's part of our difficulties in the circumstance. Now, one interesting thing is that, and relates to this previous show we did here talking about fecal microbiota transplantation, or the slang term of stool transplant, is there's a lot of research now looking at saying, hey, if it's an interaction between an individual's gastrointestinal system and the bacteria within it and their immune system, perhaps if we change those bacteria, that we might be able to make a difference in terms of actually putting a person in remission or even curing him. And that's ongoing trials right now are looking at that. But
that's the stool transplant.
Yeah, and that's the ultimate biologic. So
and we have talked about that. And if you watch that show on stool transplantation, you'll learn you'll learn more. So
Thank you for coming, Dr. Phillips.
Thanks so much for having me.
Appreciate it.
There's always more to learn about these things.
Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening. I'm Dr. Greg Leach. This is Dialogue with a Doctor. I'm here with my co-host Jim York, and we're talking this evening with Dr. Raymond Phillips, who is a practicing gastroenterologist in Naples, Florida. We've had him on the show before, and we welcome him back again.